obtaining a PhD from Cambridge in 1999. He did neurosurgical training at Cambridge and King's College London, and he developed the Cambridge protocol for the derivation of cancer stem cells for human brain tumors. He was recently appointed as an HEFC clinical senior lecturer at Cambridge in the Department of Clinical Neuroscience. Please welcome to us.
Thanks so much. Thank you. Okay, so in essence, to a certain extent, following on from some of the principles that were very nicely described in the previous talk, I want to focus on a particular area of cancer, which is brain cancer, and particularly the commonest and most aggressive type of brain cancer, glioblastoma. I'm going to briefly introduce you to the background of what that is and outline the current clinical management, and then I'm going to focus on the development of fluorescence as a clinical tool, and then our development or extension of it into research protocols, and then the implication that some of the novel biological insights that we've made as a result of applying that technology have for interaction with other technologies. Sorry. Couldn't have made that, could you? So, brain cancer has a disproportionate burden of disease to a particular individual, and it's poorly recognised. It accounts for about 7% of cancer deaths, and is the third leading cause of cancer-related death in middle-aged men. The fourth leading cause of cancer-related death amongst women within the age group 15 to 34. Low-grade pilocytic astrocytoma is the commonest solid tumour in children, and 40% of systemic cancers will spread to the brain at some point. The prognosis for these patients is very poor, and I want to just illustrate this with some data that was published in 2008, which looked at 3 5-year cohorts of patients and then averaged the change over the 5-year time and made predictions for what would happen in the subsequent 5-year cohort. And in essence, what I want you to note is that when you look at survival, this is all negative. And these were the statements that came from the data. Basically, brain tumours are one of the rare cancers where there isn't really any improvement. And that the overall trend, at least as far as the data to 2000 is concerned, was downward. Now, I have to put a caveat on that because this data predates the introduction of one of the more modern chemotherapy regimes. So this situation is likely to have modified. But it serves to emphasise the nature of the disease. Current clinical management involves some or all of these 3 modalities. First of all, you start with surgery because, in essence, as far as the clinical oncologists are concerned, no meat, no heat, and they won't give any radiotherapy until they've got a histological diagnosis. And there are 2 ways we establish that. One is to lift the skin flap, take off a plate of bone, access the tumour, remove a substantial amount or as much as we can. That's called a craniotomy. Put the bone flap back, stitch the skin up, and then they go back home to tea and medals. The other is a biopsy, which is simply the delivery of a needle into the tumour through a small drill hole to establish a small sample to establish histological diagnosis. And then that is followed by radiotherapy, which can take one of 2 forms. It can either be radical in intent, where the idea is to destroy residual tissue and slow down the time to progression of the rate of recurrence. And it's the only modality that has had a significant impact in terms of survival, and that impact is still relatively negligible, and it has set the standard of care for the last 30 years. Palliative radiotherapy is simply a means of limiting the rate of growth to buy some degree of quality of time in patients whose life expectancy is measured in weeks rather than months. And then chemotherapy, which I'm not going to go into any detail here. Yesterday, one of the concepts that was alluded to was this idea of integrated systems. And I think in terms of cancer management, I would extend that further to say not only is it necessary to integrate the different therapeutic modalities, but it's also necessary to integrate the process of care. And one of the important developments that has been established is this idea of understanding the patient journey from their point of initial contact with the medical sector, and to try and, by understanding that journey, understand how we can interact with it in a therapeutic and research sense at every stage of that journey, and thereby enhance recruitment into clinical trials by getting tissue at the time of surgery, by banking that tissue, by putting patients into research studies that include not just an understanding of the biology of the disease, not just introducing new technologies, but also, for example, understanding and improving quality of life for what life is left of us. So fluorescence as a clinical tool is something that was developed, at least as far as brain cancer was concerned, by a neurosurgeon in Germany called Walter Stummer. It's based on the idea of heme biosynthesis, and the idea, this is the pathway in which heme is synthesized, and the rate limiting step is at this level here. And if we apply exogenous aminolinolenic acid, then we can increase synthetic activity along this pathway. And in glioblastoma, at least a proportion of the cells are deficient in an enzyme called ferrochelatase. Ferrochelatase puts iron into the heme ring. And in the context of increased exogenous aminolinolenic acid, there is a buildup of the precursor molecule, protoporphyrin 9. And protoporphyrin 9 is a fluorophore. So the idea then is that because there is selective accumulation, incident light in the operating room will result in an emission of a longer wavelength, which we can visualize directly in real time. And what we can do is, by means of a dichroic mirror, which allows the longer wavelength emitted light to pass through, we can visualize what is going on, and we can see under white light conditions, and then we can identify areas of disease under fluorescent conditions. And from a clinical perspective, there is evidence that this will improve progression-free survival. We're talking months, not years, but will have an impact on the time at which the disease recurs in a cohort of patients. And if you take this population as a whole, you can see from this graph that this population here, it has no impact on. These guys are going to die, and they're going to die quickly. It also has little impact on these patients out here. And again, I think what this emphasizes is that we have to think of these technologies in the context of the overall biology of the disease. And clearly, patients out here have a very different disease to patients out here. So we have to bear that in mind. But nevertheless, we can utilize these technologies to facilitate clinical resection. You don't need to be a brain surgeon to work out that this area here is probably nasty. This area looks relatively normal until you start looking at it under fluorescent conditions, and you find that what looks normal under normal operating conditions is actually riddled with disease. And there's a growing body of evidence, admittedly not class 1 evidence, that not only does it improve progression-free survival, but that by enhancing this surgical resection, we can improve overall survival as well. So we began using that. We established the use of fluorescent-guided resection as a clinical tool, and then began to extend it as a research tool. And the reason that this happened is when I did the first case, it caused quite a lot of interest. And there was a reasonable sized audience in the operating theatre, and I decided that I would go for the dramatic. So I opened up the tumour, and I got the most obviously necrotic, nasty area that I could find, and flipped the switch on the operating microscope, so we went from white light to blue light, and it was as black as the ace of spades. And there was this soft touch from the professor behind me, and I thought, oh. And then I started pecking at it somewhat disconsolately, and gradually I started uncovering fluorescent material, and I realised that what I'd done is I'd gone for what under white light conditions we would consider to be the active disease area. In actual fact, I was in the necrotic centre of the tumour, and that didn't take up any fluorophore because the cells were all dead and dying. It was the mass around it that took up the fluorophore. So it dawned on me that you could begin to use this to interrogate distinct compartments of the tumour. Because in theory you have 3 points. You have the necrotic bit in the middle, you have the mass, and then at the end of the day, when you've removed the fluorescent area, you've got the non-fluorescent margin. So we began to do this in patients recruited into clinical trials by giving them the fluorophore preoperatively, allowing sufficient time to elapse for it to accumulate in the tumour mass, and then take samples that were non-fluorescent from the necrotic core and the margin, and then fluorescent samples from the tumour mass. And basically what this meant is we could start to look at different areas of disease. You've got the necrotic core, you've got the fluorescent mass in what looks like normal tissue, so you're identifying areas that you would previously have left alone, and then you've got the non-fluorescent margin where you can take biopsies and samples from, because this is what we would class as the residual disease. This is what we are leaving behind for the radiotherapy and the drugs to hit. And the issue here is that normally we're aiming to target, this is a contrast scan, showing the tumour mass with the necrotic core in the middle. And up to now, what we've tried to do is take away most of this as best we can. And what we're finding is that the disease actually goes into areas that we've not been in before. It's new territory. Now, we have already established in the lab a protocol by which we can take cell samples and we can derive these cell populations, and we can show in vivo that these cells are tumour competent. They're capable of recapitulating some of the features of the glioblastoma. And we went on to begin to assess whether or not the use of the fluorophore impacted on our capacity to isolate these cells, because using these tumour-initiating cells as in vitro and in vivo models was a refinement and an improvement on the existing models that were available. So you've seen these clinical pictures, and what we did is we took some samples from the fluorescent mass and we started growing them, and we compared fluorescent tumours with patients' tumours who've not had 5LA, the non-fluorescent tumours. And what you've got here is log linear growth showing self-renewal, exponential growth. And when we stained them for some of the markers associated with the neuroglial lineage, we got expression, often aberrant expression. And when we looked at taking the tissue, deriving the primary material, and then allowing these small clones to evolve, and we looked at the clonogenic index, the capacity of these materials, these samples to generate tumor-forming clones, there was no effect of the use of the fluorophore. So that was good news. But to back it up, we did some further analysis. We used HR mass spectroscopy and compared the fluorophore positive and negative samples, showing that metabolically they were identical, and in vitro they formed tumours in exactly the same way. We then went on to look at how these samples grow. And this is the fluorescent tumour mass, again log linear growth, expansile self-renewal, and tumour formation. This is the margin, the non-fluorescent margin, and an example of a micrograph, and the necrotic core. So both the non-fluorescent materials declined rapidly, particularly the necrotic core. We never really got cells. But just to be on the safe side, we exposed these different areas to HR mass to see if there was any differences or similarities. The necrotic material revealed basically lactate and lipids, evidence of cell death and cell debris. Confocal microscopy of tumour samples from the tumour mass, the necrotic core and the margin confirmed that there was no visible fluorescence in the non-fluorescent samples. And of interest, what we did find is that there were one or two markers, such as N-acetyl aspartate in the marginal tissue, which are associated with stem cell invasion of normal neuropil. This is a signal that's been reported in the literature. So we had some differences between the mass and the margin. So we then went on to do an array-based approach to look at candidate genes that were associated with the stem cell signature. And what we've got here are 4 genes, NOTCH2, SOX2, GFAP, and nestin. And what we've got are 3 tumours. And from each tumour we've got the mass and the margin, the mass and the margin, the mass and the margin. And what we found, to our surprise, is that the margin cell did not express a stem cell-like signature. So we assumed that these were not self-renewing. They did not express the genes normally expressed by tumour-competent stem-like cells. So when we did an in vivo assay to assay the effect of whether or not they would form tumours in vivo, we were expecting no tumour growth. And what we actually found was that the margins would form tumours. Not in every case, but in most cases. So the margin cells had a different phenotype, but they retained tumour competency. And that's an important point I'll come back to. The other thing is that the fluorophore administration allows us to establish an objective surgical endpoint. You can tell that you've got rid of the disease in this example, but it also means that you can identify when you have not got rid of the disease. Now what we've got here is the use of the fluorophore to recognise that there are circumstances when we leave disease behind. And what I'm going to show you are a couple of micrographs down the operating microscope where we are deep inside the brain, moving into these fluid-filled areas in the brain called the ventricles. And this is where cerebrospinal fluid is synthesized and circulates. And it means that the disease has penetrated. Now, what this shows here, this is the white light micrograph. This is the choroid plexus just here. This is the frond-like material that produces the CSF. This is the ventricular lining, and this is the margin of what is resected tumor. That looks, you probably have to take my word for it. I know there are 1 or 2 neurosurgeons in the audience, but basically that looks pretty normal. It's clean, it's white, it doesn't show any abnormalities. So this also looks pretty normal. But when we look at the fluorescence, what we can find is that although we've resected the tumour mass as we've come through the mass of the brain, when we get to the ventricle, we can see it extending along the ventricle walls into the distance. And there is no way that we can resect that. We have biopsied it and confirmed that it is disease, but that is surgically unresectable, particularly if it's deep-seated in here, heading over the thalamus or the head of the caudate or other critical deep brain nuclei. So the fluorophore can also tell you when you are leaving disease behind and when you are doing so deliberately. So at this stage, we're able to show that different regions of the same tumour can be objectively identified. And that allows us to start doing targeted biopsies and taking things further. Each region appears to contain aberrant tumour cells, and these appear to be endowed with significantly different metabolic profiles, in vitro proliferation and tumour formation. Only the cells derived from the fluorescent mass appear to give rise to multipotent, long-term, self-renewing, expanding cancer stem-like cells. And interestingly, the margin cells are tumorigenic in vivo, but don't behave as we would expect them to do in vivo, in vitro. And in particular, they don't have a stem cell molecular signature. And further experiments are ongoing in order to try and better characterize these cell populations and understand the nature of the disease. So what then the rationale for local therapies? We know that we now know that tumor-competent cell populations persist in the non-fluorescent tumor margin. We know that this marginal disease appears to have a distinct biological phenotype. And therefore the assumption that has hitherto held that the resected material is representative of the residual disease left behind, and therefore assays of therapy based on that tissue and its understanding can be challenged. But the question is what to deliver and how to deliver it. At the moment, the only standard available for routine use are these Carmustine wafers. Now these are polymer-based, they're like little toluenes basically, and they're impregnated with Carmustine, which is a chemical that's been used to treat brain tumours with marginal success for many years. And so what we're doing at this stage is setting the scene by undergoing a phase 1-2 study to identify whether or not combining these two technologies is safe, and hopefully going on to an efficacy study to address the question, if we can get an enhanced resection and the residual disease we're leaving behind is different to what we're taking away, at least some of it is this a valid therapeutic tool? And clearly we're going to have to think about the clinical impact of these novel biological insights in terms of how we think about delivering new technologies or additional technologies over and above the existing Carmustine wafer type technology. And there, I've already had a chat to people who've got interesting ideas about different technologies that can be used, whether we've got mechanical pumps, encapsulated cells, stem cells, which I'll mention briefly, or direct injection of viral vectors. One of the problems with all of these is the issue of volume of distribution. If you are going to stereotactically inject into specific points in the brain or specific margins around the tumour, you need to do multiple injections in order to get the whole of the volume of the disease. That is traumatic. There has been a trial injecting an adenovirus which contained the HSV-TK gene, which sensitized those cells to ganciclovir. So the injections were made, the patient went back to the ward, they were given ganciclovir, the idea being that these cells that were transfected with the adenovirus would die, there would be a bystander effect, and we get more cell death. The reality was that the technology had a limited impact on the disease process and has since been abandoned. Another concept is this issue of pathotropism. There is evidence that if you take neural stem cells, human fetal stem cells, they will migrate towards areas of disease. And that can be applied to cancers, and it can be applied to focal areas of degeneration or injury. This is an experiment that was reported from Karen Abudi's lab a long time ago now, in the early 2000s, where they're using luciferase to identify these cells as they migrate across the corpus callosum towards a tumour on the opposite side and gradually accumulate. Another area that is causing increased interest is the use of pluripotent stem cells. This idea that you can take pluripotent stem cells, such as embryonic stem cells, and use those. What is more interesting is that you can now take cells such as a fibroblast and you can reprogram it. So it becomes pluripotent, and then you can change its direction of development to generate neural stem cells. And this is the first reported paper where targeting glioma using induced pluripotent stem cell technology. And one of the things that I wanted to draw attention to for the purposes of this audience is the range of different specialties that are involved in developing this technology and taking it forward, from bioengineering, biologists, and, God forbid, the old neurosurgeon. So we've teamed up with this chap, Pental Lauer, who has established he works at the Sanger Centre, and he's established what we refer to as SHIPs. These are Sanger human-induced pluripotent stem cells. And David Ryan in the lab is working on using these ships as vectors for delivering a variety of technologies, including nanoparticles, lentiviruses, and possibly even gene therapy. We have candidates across those areas. We're also interested, picking up from the last talk, on the nanotechnology, and Sonali in the lab is working on developing targeted nanomedicines for glioblastoma, utilizing the advanced model systems, or the more refined model systems that we can derive now using the fluorophore-based cell sampling. So the issues you've got that have been eloquently described previously, so I'll not go over them too much, other than to say that we can deliver targeted drugs and we can visualize what's going on at the same time. And these are already in active trials within glioblastoma. There are papers coming out all the time about using different types of nanoparticle. In our particular case, we use gold nanoshells because they're inert, and we use, the rationale is that we are trying to coat these nanoparticles so that they will target specifically these tumor-inducing cells using special designed proteins. And also, we're interested in trying to develop a nanoparticle that will synergize with radiotherapy. So the idea is that we inject the nanoparticle, we deliver the nanoparticles by whatever means, and that the patients are then exposed to the standard radiation, which triggers the release of Auger electrons, and that results in more damage to the adjacent tissue, although that's relatively non-specific. We also are able to conjugate drugs onto these shells and are working on specific targeted deliveries of things such as cisplatin. So nanoparticles for targeting these tumor-competent stem-like cells is something that I think is a viable long-term project, and I think it's something that we are continuing to work on. So in summary, brain cancer is one of the most lethal of human diseases that you could get. The median life expectancy is 14 months. The number of patients surviving 2 years is about 12%, and the 5-year survival is about 2 to 4%, depending on which paper you read. The fluorescence technology can be used as a clinical tool, that's established, and as a research tool. I think clinically it will gradually, over time, set the standard for how we should approach this disease surgically in order to optimize and standardize what we do as much as possible. And as a research tool, it allows us to objectively interrogate and define distinct compartments within the disease, and allow us to make some novel biological observations, refine our model systems, and then interact with other technologies in a meaningful, synergistic sense. And I think, as everyone's already realised, it will not, one single technology alone isn't going to be the answer to a disease like cancer. A multidisciplinary approach is going to be essential. And I think meetings like this, where we're starting to learn common language that everybody understands, are fundamental to that process. So I'd like to finish by acknowledging Sarah Puccirillo in the lab, who's doing the fluorescence guided work, Sonali, who's doing the nanotechnology, and David Ryan, who's not on this photo, who's doing the ships, which are starting to sail. Thank you very much.